Today's topic is going to be asthma remission. And this is a topic that I'll say it comes up in the community all the time. This is one of the most frequent topics of conversation that you'll hear from folks who will say, I had asthma, but I grew out of it, or some combination of that. So I'm really excited for the talk today. And we'll get to the next slide so that we can get going. Oh, I'm today's moderator. My name is Matt Seymour. I'm the executive director of Mobile Care Chicago, where we have free asthma and allergy clinics that travel around to different neighborhoods of Chicago and provide medical care for people on a continuous basis. I'm also the president of the board of the Chicago Asthma Consortium. For today's agenda, we'll do a very brief introduction into the Chicago Asthma Consortium and what it is that we do. And then I'll pass it over to today's speaker, Dr. Gupta. Afterward, we'll have a question and answer session, and then we'll close at 12:30. And a little bit of housekeeping. So you won't need your video or your audio today. We're going to work exclusively through the chat. So if you do have any questions or anything you want to throw out there as we go through the presentation, you're welcome to do that in the chat. I'll aggregate everything as the moderator today, and then I'll make sure to ask any questions that we have to Dr. Gupta at the end of the presentation. Um, we'll also have a survey at the end of the webinar to just sort of solicit ideas for future lunch and learn topics, and then also, any suggestions you have on how we can improve the format of these discussions. We're always welcome to that, and we do read all the responses, so please do submit to the survey. This is also a chance to just network with other people who work in asthma. So if you want to use the chat to just introduce yourself, the position that you have, the organization you're with, or just what you're interested in when it comes to asthma, please use the chat, and you'll see a couple of folks active in there as we go along. And a little bit about the Chicago Asthma Consortium. So we've been around for 30 years now. We're an organization that seeks to improve the quality of life for people with asthma. And the main way that we do that is through three branches: advocacy, education, and collaboration. So really what we're trying to do is bring together all of the different stakeholders who are passionate about asthma issues, or are caregivers of asthma, or people with asthma, people in medical care, public health, business leaders, community-based organizations, and to marshal all of our efforts so that we can be on the same page and can also make sure that guidelines-based care is promoted so that everyone with asthma can have access to quality care, education, support, and ultimately can live a life free from distractions or interruptions because of their environment. You can learn more about us at chicagoasthma.org, our website. Or in the next slide, I'll also tell you how you can get involved. Look at that. So we're a volunteer organization. Everything that we do works through different committees. We have a community advisory board that weighs in on different research projects that have to do with asthma. We have a community engagement committee that is specifically trying to promote education to different areas where reaching a provider is very difficult. We have a fundraising committee, a membership committee, and then we also have a professional development committee. And that's the group that puts on forums like the one that we have today. If you're interested in joining any of these committees, you can email us at info@chicagoasthma.org, or you can just send me a direct message in the chat and we can talk about that. But instead, I'll get to our today's presenter, Dr. Gupta, and I'll do a brief introduction. I'm really excited to have Dr. Gupta here today. She's an assistant clinical professor at both the State University of New York Downstate Medical Center and Mount Sinai Medical Center in New York. She holds certifications from the American Board of Allergy and Immunology, the American Board of Internal Medicine, and the American Board of Pediatrics. Dr. Gupta practices in 29 states through telemedicine and also sees patients in Brooklyn, treating both adult and pediatric patients with asthma, environmental allergies, allergic skin conditions, immune disorders, and food allergies. She is a volunteer national spokesperson for the American Lung Association, as well as past president of the New York Allergy and Asthma Society. Dr. Gupta is co-host of the Itch podcast, which I'll put a link to that in the chat, dedicated to helping patients understand their allergic conditions. So with that, Dr. Gupta, thank you for being here, and we'll get to your presentation.
Hi.
Oh, Dr. Gupta, you're on mute.
Oh, can you guys hear me now?
Yes.
Okay. Sorry, just pulling up the slides. Okay. So, it's so nice to be here with everyone today. So we're talking about a topic that's very new. And so I was telling everyone that I would not consider myself an expert in this. I don't think any of us are experts, and the definition is still kind of evolving about, and the conversation is evolving about asthma remission and what does it mean and how can it be achieved. And so, but I think it's an important conversation, and I think it's important just to think about it and to understand what we're trying to get to and why people are talking about it. And ultimately, we need a lot more kind of consensus around exactly what we're talking about when we're talking about asthma remission. And so, asthma overview, I think everyone here understands what asthma is. It's a chronic inflammatory condition of the airways. It affects millions of people worldwide, and that's both children and adults. And our traditional focus was on symptom control and prevention of exacerbations, and our emerging goal is achieving remission as a new therapeutic target and thinking about that as early as we possibly can. And so, control, we'll just kind of review it really quickly. There's lots of different definitions, but we can use the rule of twos for
Excuse me,
assessing asthma
Dr.
control.
Gupta, we're not seeing your slide. I'm sorry.
Oops, you're not seeing my slides?
No.
Uh-oh, I don't know what happened. You're still not seeing them?
We could see the slides, but it's not in presenter view.
Yeah, so if you
Oh.
can start from the beginning.
Uh-oh.
I mean, not the. Yeah.
Is that presenter view?
No, perhaps you're showing a different screen if you have two monitors.
It's showing this one is the one that's green, which is usually the share. Sorry, let me try that.
Can you start it in a slideshow and then start from current slide?
Yeah. Did that work? Oh no. Okay, wait, let me stop share. Let me try it again.
I apologize, Dr. Gupta, but it could be that it looked like it was at 50% view on your presenter mode. On the
Oh, really? Okay.
Oh, wait, that's perfect.
Yeah, that's perfect.
Is that okay?
Yes.
Okay, maybe I
Yes.
just needed to do it again. Okay, now it's not going back with me. Okay, there we go.
Perfect. Thank you.
Okay. So yeah, asthma control is, we've been thinking about asthma control, and that's really how we assess whether we're going to start a new medication, reduce asthma medications. And that's really what, the crux of what we're doing when we're evaluating patients. And, we use the rule of twos, which I think everyone, again, should be familiar with. But, do you use your rescue inhaler for asthma symptoms more than 2 times per week? Do you wake at night more than 2 times per month? Or do you fill your rescue inhaler more than 2 times per year? And if a patient answers yes to any of these, then we know that their asthma is not under the kind of control that we want it to be. And GINA, which is a global initiative for asthma, they have, they have a little bit of a different definition of asthma control. And basically, they look at it in 2 domains: the symptom control and future risk of adverse events. And so they also use kind of like asthma control questions with the yes or no parameters. And if you answer yes to 3 to 4 of these, then you're uncontrolled. 1 to 2, you're partially controlled. And if you answer no to all of them, then you're well controlled. And the risk factors that they're looking at is essentially looking at the FEV1, and the lower the FEV1, the higher the risk. So we just want to kind of pay attention to those kind of things, and that's what we've been doing. And so asthma remission, which is what we're talking about today, asthma remission, if you look at it as a model within the medical community, it's talked about. I know we mostly think about it when we're thinking about cancer, right? When someone's cancer is in remission, everybody's super happy. And cancer is a little bit of a different topic, whereas rheumatoid arthritis can, I think, better match when we're looking at disease state and asthma. And so, rheumatoid arthritis is an incurable inflammatory condition, also, which is the same thing as asthma. It's a disease progression results in irreversible joint damage and visible disability, right? And we know with asthma that disease progression in asthma results in irreversible lung function and decline in lung function and disability that's not necessarily visible, but it's underestimated for people at times. And so those two kind of meet closely. And then with rheumatoid arthritis, they have multiple targeted treatments, including disease-modifying anti-inflammatory drugs that are available with the realistic goal of clinical remission. And so clinical was a term that a lot of people are talking about because neither of these conditions are curable, right? And that's in that's kind of in that earlier definition that we were talking about. They're not curable conditions, but maybe at some point we will be talking about cure. But at some point we're achieving such kind of super control that it looks like it's in remission, which means that it's essentially not there, right? And we're not thinking about it. And that's really what we're talking about when we're thinking about remission. So defining asthma remission, so clinical remission. So there's different definitions right now. There's clinical remission, which is the absence of clinical significant symptoms and exacerbations for at least 12 months. Complete remission would be clinical remission plus normalization of lung function and airway inflammation. But we know that complete remission may not be possible in later stages of asthma, right? So if someone's had severe asthma for a significant amount of time, their lung function may already be compromised and they may have scarring, which results in their lung function never normalizing to normal standards of lung function. And so, that definition of complete remission may not ever apply to that severe asthmatic. And then the other thing that we need to think about with remission is that they're talking about it in terms of on or off treatment. So it doesn't mean that you need to be completely off of therapy to say that you're in a state of remission with asthma, which to some people might feel kind of confusing. But again, we're not talking about cure. We're talking about just where the disease is in a state where we're not thinking about it at all. And I think that the reason that asthma remission is really being talked about is because we want to have higher standards besides just control. We really want to have it be in a state where the patient feels like they don't have the condition at all. And so several countries have recommended clinical remission definitions. And again, there's a lot of differences. And so there really isn't good consensus. So if you look, one of the bigger things that seem to be different is symptom assessment. So here, Germany, Spain just says absence of symptoms, whereas Italy, Japan, and the US are using more kind of objective measures of symptom assessment with the ACT and the ACQ, where you can actually put a score to it. But then you can see that different countries are putting different scores down as their definition of what clinical remission means. And so that's really where things get a little bit confusing, because if we're using this, and I have another slide right here that kind of goes into when people talk about remission, clinical remission in studies, we really have to look closely at what they're talking about when they're defining their version of clinical remission. So what is their standard of their ACQ or ACT levels? And based on that, we may have really a different prevalence of clinical remission, just because some of the definitions require the patient to be under better control, essentially, than others. And so that's why it's so important for us to really come together as a community and put a clear-cut definition of what remission really means, because otherwise, when you're talking about clinical remission to somebody, you may be using one definition and they may be using a different definition that they've seen in a different publication. So today, what I'm going to be talking about is well, first I'll go into this, but today what I'm going to really be talking about is right now there's a consensus statement that was put together by the American College of Allergy, Asthma, Immunology, the American Academy of Allergy, Asthma, Immunology, and the American Thoracic Society. So they brought together a group of individuals that came together to put a statement out as 3 different large organizations of clinicians that treat asthma, in order for at least there to be maybe some consensus in the US of what we're talking about when we talk about clinical remission. So how do we assess remission in asthma? I've kind of talked about this a little bit, but we're looking at clinical symptoms. So sustained absence of symptoms, again, is it 6 months? Is it a year? We're looking at validated instruments, but again, this is where we get into the question of what are the definitions and how low or how high do we need that number to be in order to qualify as a parameter for remission? Use of bronchodilators, what are we thinking about for that? Is it never using bronchodilators, or what is that definition? No exacerbations. So when we're looking at that, we're talking about corticosteroids, we're talking about emergency room visits, hospitalizations, no missed school and work days. And then we're looking at lung function, stable or normal lung function, and improvement of lung function. So again, for a lot of severe asthmatics, their normal at any given point may be different, right? Because now they have scarring and they have changes in their lung function that may not be reversible anymore. And so stable may be their goal for remission. And maybe stable / potentially some improvement in their lung function. And then medication requirements, decrease in your controller medication, again, and decrease in your rescue inhaler use. And then normalization of asthma pathophysiology. So normal biomarkers of inflammation, like blood eosinophil levels for those with eosinophilic asthma, sputum eosinophils, the fractional exhaled nitric oxide levels. And then if you're doing bronchoprovocation testing, that also is normalized, and normal histology on, again, which we're not getting very often in our patients. So again, the American College of Allergy, Asthma, Immunology, the American Academy of Allergy, Asthma, Immunology, and the American Thoracic Society came up with a framework on treatment, clinical remission. So basically, for patients that are on treatment, what does it mean for them to be in clinical remission? So they're looking at kind of 4 things: asthma-related events, background therapy reduction, lung function, and patient-reported symptom control. So we're going to go through all of those things. So So with so number one, which it seems like everyone kind of agreed to during that meeting that they had of the minds. Everyone agreed to no exacerbations requiring physician visits, emergency care, hospitalization, and/or systemic steroids for asthma. So that was something that everyone agreed to. No missed work or school over a 12-month period due to asthma-related events was also something that everyone agreed to. And so, again, we want this definition, once it is kind of really, once we come with a clear definition, to be more than just asthma control. We want it to be at a higher level than just asthma control. We really want to have a definition that isn't, that really that says remission and not just control. And so number three, they talked about stable and optimized pulmonary function testing on all occasions measured over a 12-month period with a minimum of 2 measurements during the year. And again, realizing that some patients with asthma may already have lung function that is below the accepted normal as their baseline, owing to their previous remodeling, they didn't require an absolute number to comply with asthma remission. So for example, if a patient's FEV1 is at 65% and only improves to 70% over 12 months, but meets all the other criteria for remission, they would be labeled as in remission. The patient's lung function is basically optimized as much as possible due to their fixed lung disease earlier in life. So that's the definition of, stabilized, optimized FEV1. And then number four, the criteria will allow continued use of controller medications as defined by the most recent GINA guidelines, but the work group felt that the need for a higher standard, again, for remission and not just better control. So what we're talking about here is that the patient should not be on high dose inhaled corticosteroids, that the criteria would only allow for low to medium dose inhaled corticosteroids in patients that required that. And that need to taper inhaled corticosteroids with the realization that there are no long-term studies on what that looks like. And then number five, for their definition of where they wanted the ACT, the AirQ, and the ACQ, they came up with these numbers. So the ACT should be greater than 20, the AirQ should be less than 2, and the ACQ should be less than 0.75 on all occasions measured in the previous 12-month period with a minimum of 2 measurements during the year. So again, you can see that all of this is looked at within a 12-month period. So it's going to take a whole year of kind of looking at the patient, evaluating the patient, and then really being able to say that you think that the patient is on treatment clinical remission, according to this framework. And then number 6, symptoms requiring one-time reliever therapy or short-acting bronchodilator, or if they're using SMART therapy, no more than once a month. So this one had a lot of debate between the work group members, it sounds like. Most felt that the most rigid standards of the GINA guidelines of less than twice a month was too much albuterol, but there was a lack of consensus based on the lack of data and research. So the group recommended no more than 2 puffs per month. Sorry, that's a typo. 2 months per month on average as a starting point. And so those are like the 6 major criteria, essentially, that this work group came up with. And we need, ways to evaluate daily symptoms. So exacerbations and oral corticosteroid bursts are not regular events. Using our rescue inhaler and missing school and work days gives us more information on whether daily asthma symptoms are occurring or not. And so that's why those two areas really need to be looked at more closely. And again, those two things show that this is a step above just control, and that we're really looking more now for clinical remission. So achieving remission now with biologic therapies and targeted treatments like the anti-IL-5s and the anti-IgE therapies are showing promise in inducing remission in patients. And really, I think what the hope is that when we think about remission, we're really going to be thinking about early intervention and prompt. And so looking at these treatments more early on in the course of disease rather than later on in the course of disease. And I think a lot of allergists and pulmonologists, or maybe not a lot, but I think there has been discussion of, if biologic therapies weren't so expensive, I think a lot of practitioners would want to use them early on in life, early on in the patient's disease course, in order to prevent the remodeling, as opposed to waiting until the patient really has that moderate to severe asthma and already has remodeling before starting these medications that really work, right? But cost and insurance issues prevent us from doing that. And so, maybe this definition of remission will allow us to bypass some of the insurance obstacles in getting these medications to our patients earlier. And then, of course, lifestyle modification, smoking cessation, weight management, and trigger avoidance are always important in our patients with asthma. And like I mentioned throughout, the definition of what asthma remission is going to be an evolving process. And we're still kind of figuring out what we're talking about here. And I think that the community of allergists, pulmonologists, respiratory therapists, all of you guys, we've worked so closely with the definition of control, and that kind of evolved. And I think that's what we're looking at in this next phase for asthma, is how are we really going to define that? What are the parameters that we're looking at? How does that translate into clinical management? When are we going to come to a consensus? How are we going to validate what we're thinking should be the definition? And then, of course, once that validation happens, how are we refining that definition? So again, it's going to be an ever-evolving process. So future directions, ongoing studies to better understand remission mechanisms, personalized medicine, so tailoring treatments based on the individual patient profiles, which we're all working hard to do, and guideline updates. So I think as we're moving forward, we are going to be seeing the word remission being incorporated into updated guidelines moving forward. And conclusion, asthma remission is hopefully a very attainable goal for a lot of our patients, especially with the emerging therapies that we have. Shifting focus from control to remission will hopefully improve patient outcomes. And the call to action is that we should all be thinking about it. And ultimately, I hope one day we'll actually be talking about a cure for asthma. But that's it. Thank you so much.
Thank you, Dr. Gupta. And as a person with asthma, I hope one of these days we are talking about a cure or something like that. But I really appreciate your presentation, and thank you for the sort of articulation that you gave of like how remission differs from control. I think especially in a real world context, that is one of the things that I want to go back to, is like what are some of the ways that we can articulate the difference between like what is control, especially over a short period of time, versus what is remission. And it does seem like from your presentation, like time frame of control is a part of that. But then it also looked like you were pointing to maybe some higher standards. I mean, ACT 20 and above, or the sort of like testing seemed to be a big factor, and then also step down of therapy and ICS that's not at the highest level. But I wonder if you would just give like a brief summary of like what you see as like the major differentiating factors between sort of like a methodology of control and like an ultimate goal of like remission.
So again, I would say that I think we're all trying to understand this, including me, to be honest with you. But for me personally, what I take from what I think um, people are saying about this is that yes, we need to look at the patient over a longer period of time, right? So definitely 12 months is the minimum amount of time that we're looking at all of these parameters put together, right? And we're checking these parameters at different you can hear me, right? Yeah.
Uh-huh.
And we're checking these parameters at different time points in order to really document that we fully think that this person is in clinical remission, right? And you're right in that, the no missed work days or school days over an entire year, that's a clear kind of differentiator that one of the consensus report physicians kind of really highlighted in a presentation that I listened to. And I think that ultimately what we're looking at, I mean, some people might just call it like an ultra controlled patient, right? But just termed with the word remission. And so I don't want people to feel overwhelmed with it. I think what it is it's just a new standard for where we want patients to be. We want them to be as symptom free as possible, basically, essentially, no symptoms and over a prolonged period of time versus just looking at them and over the last month, which is what we're used to doing, right? And in addition, really having our goal be that even our moderate to severe asthmatics could potentially be on lower on reduced amounts of inhaled steroids. And one thing that the definition didn't really account for was the biologics. So I just wanted to mention that when they're talking about this clinical remission on treatment, that means that they could be on a biologic. So I think a lot of people, and including myself, would say, well, wait, they're on a biologic, but we're putting such strict restrictions on what they can be on as far as their inhaled steroid, right? But again, it's evolving. And I think that this is the initial kind of criteria and the initial definition. But I think biologics, I think to be in clinical remission, just like in rheumatoid arthritis, you can be on one of those disease modifying drugs. The thought is that these biologics are disease modifying, right? And we need more studies to really say that, but we know that, or we think that if we start patients earlier on biologics, that we would prevent the remodeling, right? And
Right.
so we think that they would be disease modifying if we were to start them earlier, if that makes
Yeah,
sense.
and absolutely. And I take it that that's why we're seeing the push by pharmaceutical companies to get biologics into the lower age groups is particularly for that reason. Um, and I do want to come back to that because you said something that I think is really crucial in there, but I don't want to ignore the questions from other folks in the chat. So um, Andrea Jensen brought up something like that actually I thought of too during your presentation. So she says, as someone on a high dose inhaler and who is unable to decrease my treatment, I feel like there's no hope for me or anyone else on high dose inhalers. Good luck to anyone else who is able to obtain remission, though. So, like for folks who like, I mean, for me, I'm on Wixella 500, um, and I imagine Andrea is in a similar situation. So, like, the criteria for remission specifically is about stepping down ICS use, and you know, how does that sort of play in with high dose inhalers and people who are controlled on those devices, but like are stepping down any further, like would not be a good idea.
Yeah, I think what it is, and again, I think what it is that what we're hoping is that we would start these quote unquote disease modifying or biologics earlier. And therefore, those patients that aren't at that point, um, and even severe asthmatics, we know when they're started on biologics, they may be able to come down on their inhaled steroid prescription. But right now, the definitions are right now. Sometimes physicians don't do that. Sometimes practitioners don't do that because they're worried that if they bring down their inhaled corticosteroid, then the biologic might not be approved. But then they know that but we know that maybe their disease is good enough to come down. But again, it's like a catch-22, right? So we're hoping that these new definitions will allow for the tapering of these inhaled corticosteroid medications while on biologics. For example, so for you and for this other individual that's asking this question, would it be better, like if we are seeing that maybe your lung function is changing year after year because of remodeling potentially? So even if you're symptomatically controlled, if your FEV1 is changing or these kind of subtle things are happening, would it be better for you to be on a biologic and reduce your inhaled corticosteroid potentially? Does that make sense?
Oh, yeah.
So I think those are you might get 10 different answers if you ask 10 different allergists right now, or pulmonologists on what they think should be the answer to that question. But that's my personal answer to that question.
Yeah.
Yeah.
And I do wonder if if biologics in particular, like if this was 10 years from now and biologics were more readily available to people, I wonder if we wouldn't have a different criteria for their use. Because, one thing that Andrea brought up was that, like right now there's all these different factors that sort of make you that you need to jump through in order to qualify for biologics. And largely that's about the prior auth process and the way that they were approved by the FDA. So like if your IgE level isn't elevated enough, then you won't be a candidate for biologics. Or there's some other factors as well. So like if 10 years from now, when the research is different about the use of biologics and when these devices have been more readily available, or these therapies, I wonder if you'll see a different definition. And maybe some people who wouldn't have qualified for a biologic before, suddenly it becomes an available option.
Well, and I think that that's what the hope is, right? And so I really do. I think that that's why remission is coming into play here, is earlier use of a medication that we know could potentially be disease modifying.
Yeah.
Mhm.
Mark Rubin brought up something, your perspective on the use of smart therapy, which is more in the moment response versus remission.
Sorry. Like meaning, I'm sorry, I'm not sure what the question is exactly.
Well, Mark, if you want to take yourself off mute and just sort of give a brief explanation.
Yes, can you hear me?
Mhm.
Yes.
Okay. I had a discussion with a leading person at Quad AI a year ago who he himself is on the smart therapy. I said, before you put the patient on smart therapy, have you achieved where their lung function is approaching normal function? Or are you just prescribing because you feel for their mild intermittent asthma that this would be fine? But when you don't have the perspective of what level their actual asthma is, how do you just prescribe a smart therapy? I mean, if we're looking at remission, we really have to address the full underlying issue taking place physiologically. And he goes, well, it works for me, which to me is not a way I'd see it.
I think smart therapy is, I mean, if I'm understanding what your comment is I think smart therapy, it addresses a couple of different issues, right? Number one, and I'm sorry, I have a little bit of construction going on in my home, so that's what that background noise is, but I hope you can still hear me. But smart therapy addresses the number one, not having the patient not get confused about which inhaler is for what, right? And so it has definitely helped, I think, patients that were maybe using their albuterol as their controller, and also just albuterol in general being not as safe as we had once thought. And so it's really like trying to solve for that problem. Number two, I think that smart therapy, so it really, like, controlling the inflammation even during like a viral exacerbation in that moment, and having something that's going into the airways to help reduce the inflammation that's caused by the virus, I think we know can help in improving outcomes, right? And improving the time that it takes for someone to feel better. So I think smart therapy has a number of use case scenarios and benefits, but it might not be for everybody. And again, with insurance, we might not be able to use it for everyone in general. But I think, yeah. So I hope that helps or gives my perspective. I'm not really sure who you spoke to and exactly where that conversation went, but that's kind of my perspective into that.
And one thing having to do with the high dose, people not having control, because coming from a pharmacy education background, pharmacogenomics is definitely research area, meaning cancer and everything else. And if you're in high dose, it could be that that particular ICS is not matching with your genetics. It might be worthwhile to try a different ICS because to change your chemical structure, your body might be more responsive than it is with the current ICS.
Thank you, Mark. And okay, so I do want to at least try to get through some of these questions. Dr. Gupta, if you can stay around for maybe just like 3 more minutes.
Yeah, I
Um,
definitely have 3 minutes, but then I do have to get off,
Okay,
unfortunately.
yeah, same. But thank you for making the time.
Mhm.
We did have another question from Jade. Do you have an opinion on probiotics? What about other food and diet modifications, um, separately from avoiding diagnosed allergens, as a, a potential therapy to help with asthma treatment?
Mhm. So probiotics, again, is not my specialty, but it is something like the microbiome is something that we're looking at in general for a lot of medical conditions. I do think that inflammation can be mediated by the gut. And so I don't think that there's anything wrong with probiotics. If you've ever looked in the Whole Foods aisle at the number of probiotics available, there's probably a million different products that are out there. And so just even for myself, when I've gone to try to figure out which probiotic do I want to be on, it's very confusing right now. So, are we going to have more tailored probiotics for different medical conditions? I personally think yes, at some point we will. As far as foods causing asthma, isolated asthma, and as you guys all know as practitioners, we don't do food allergy testing in asthma patients. We don't do pan food allergy testing really for any patient. We have to have one-to-one symptoms. So meaning that for a patient to truly be allergic to a food, they need to eat it, and then within minutes to up to 30 minutes, they need to have symptoms of anaphylaxis. So shortness of breath, wheezing, facial swelling, vomiting, diarrhea, all of these things need to happen within that time frame. And if that doesn't happen every single time that the person's eating the food, they're likely not allergic by definition. Right now, our testing only looks for that particular type of allergic reaction. So we cannot look at sensitivities or if a food causes like mild inflammation in the person's body. There is no test to look at that. And so we really have to help our patients understand that food allergy testing will not cure their asthma. So that's really, really important, that we have a lot of patients that come in asking for food allergy testing for their asthma. And we know that that's not something that we need to be doing for the cost of medicine, and also like just meaning for, just overall cost of healthcare. It's not necessary to be doing that for our patient management in general.
Yeah, thank you. And That's a Dr. Gupta. It's funny you say that because we were one of the mobile care providers and I were literally just talking about this yesterday. It's very common for, especially for new patients, to come into our clinic and specifically request food allergy testing as an asthma control mechanism. So
Yeah, and I think what's
yeah,
important to tell patients, and I think I have my spiel down to a science where people really do understand it, is that this is an internal disease, right? So your body is producing inflammation, and the external environment can play a role if you have allergic asthma, of course, with environmental allergens, and food allergies can cause asthma, but it's a very particular reaction, right? Isolated or like just having increased amounts of asthma symptoms with multiple foods, and whether you're eating or not eating is not a food allergy. So again, I think the key message to patients is that we do not have any testing for food sensitivities at this time. And that's like the major thing that people need to understand, is that food sensitivity is a totally different topic. If they personally feel that milk makes their asthma worse, then they shouldn't drink milk, right? But we cannot validate that with the testing that we have. So, and we, as practitioners, we all need to be on the same page about that. Otherwise, I think that's what creates misinformation and confusion among asthma patients.
yeah. Well, I think we'll have to do another sort of like follow-up on this at some point, but I know we're way over time, and Dr. Gupta, thank you so much for staying over, but I think we'll have to conclude it there. And yeah, we did put the survey in the chat. I really would encourage everybody to take the survey, let us know anything that we can do better, or different topics that you want to know about. And I'll just end by saying, Dr. Gupta, thank you so much for a great presentation and discussion. And yeah, we'll look forward to seeing everybody again next time. Thank you.
Thank you.